Again, thank you for joining. This is a little bit off cycle for us, but this is our last AI4C Artificial Intelligence for Clinicians lecture this academic year. And we're delighted to have Dr. Tessa Cook here for us today, who's going to talk about if a picture is worth 1,000 words, what are words worth? And she's going to talk about natural language processing and the future of radiology. Um, as you know, this series is every second Thursday of the month, September through May or June sometimes. And we've had a wonderful slate of speakers this year. You can see what we've had in the winter months and Dr. Cook today. You can view our past recordings at the link there, and Carrie Ann will put those links into the chat. Please do fill out the survey. That'll help us plan future meetings. You can also follow MGBAI at the link there and on LinkedIn and Twitter and so on to see some of the other activities that we are doing through our office. But today we are absolutely delighted to have Dr. Tessa Cook. She received a Bachelor of Science in Engineering and Computer Science, also in Biomedical Engineering, and a Master's of Science in Engineering and Biomedical Engineering, all from Johns Hopkins University. She received her MD and her PhD in Bioengineering from the University of Pennsylvania School of Medicine and School of Engineering and Applied Sciences, respectively. She's an associate professor of radiology at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, and she's the vice chair for practice transformation in the Department of Radiology. She has a strong background in imaging informatics, having completed her doctoral work in the quantitative imaging processing in the Penn Image Computing and Science Laboratory. During her residency, Dr. Cook developed Radiance, which is really only the second open source radiation exposure monitoring tool, and it's been used worldwide since 2010. She's an active member of multiple radiology societies, national radiology societies, including the Society for Imaging Informatics in Medicine, the American College of Radiology, the Association of Academic Radiologists, and the Radiological Society of North America. She received the E. Stephen Amos Jr. Fellowship in Quality and Safety from the ACR in 2011. And she was one of the Association of Academic Radiologists Giraffe Fellows from 2013 to 2015. Dr. Cook enjoys an academic appointment in radiology that enables her to continue her clinical work, and her specialty is cardiovascular imaging. And she does research in imaging informatics. She's the director of a wonderful fellowship there of imaging informatics in the Department of Radiology, and she's clinical director of 3D and Advanced Imaging Lab. Dr. Cook's research sits squarely at the intersection of imaging informatics and health services. And in her various roles, she pursues innovative methods to enhance the delivery of longitudinal patient care in radiology and to improve radiologists' workflow. Dr. Cook is a past chair of CIIM and has been inducted into the College of CIIM Fellows, a very high honor. She's also received the inaugural Ruth Dayhoff Award for the Advancement of Women in Medical Imaging Informatics. Dr. Cook's a wonderful collaborator, an educator, and a co-founder and co-director of the National Imaging Informatics course. It's a curriculum developed online, given twice yearly for the week. It's now international and open to radiology residents. But today, she's going to talk to us about her work in natural language processing. If a picture is worth 1,000 words, what are words worth? Natural language processing and the future of radiology. So, Dr. Cook, I'm going to stop sharing and allow you to take over.
Thank you so much, Dr. Andriol, for that very kind introduction. Can someone confirm that you can see my slides?
Perfect.
All right. Well, thank you everybody for joining today for this talk. I do have some disclosures, mostly leadership roles, and most notably, I consult for Bayer and I'm on the advisory board for Sectra. I do want to start with a disclaimer, which is that I'm a pretty good photographer, and you'll see some of my pictures kind of peppered through this talk, but I cannot draw. I drew that little sketch that you see on the screen maybe about a month ago. So I'm not kidding when I tell you that I still draw like I did when I was 5. So I did use AI to make some graphics for this talk, but the content and the ideas are original and are mine. So I was in DC a couple of weeks ago. So it's tigers and bears, not necessarily in that order. But it was a beautiful spring day, and all the animals were quite happy to oblige my camera here. So, despite the dire predictions for the fate of radiologists now almost 10 years ago, and even some new recent predictions that keep trying to tell us that our jobs are going to be obsolete, radiology AI is here. And, there are many use cases that would suggest that the combination of radiologists and AI will lead to better patient care. And there are a number of potential areas where you can actually integrate AI into the clinical workflow, into the operations of a radiology department or practice. I find myself, especially given the topic of this presentation, I find myself more and more wishing that AI had come to radiology in text and other kinds of data before it came to us in pixels. But the fact is that ImageNet did inspire this new revolution, and so many of our use cases are pixel based for findings detection, for case triage. But, I'm so excited to be able to show this slide and say that EMR search and EHR summarization is no longer a potential future application, but is now a use case that is very much in the pilot phase for some organizations and actually in practice for others. And there's a lot of power in what we can do with current NLP techniques and hopefully future NLP techniques. A lot of smart reporting applications, schedule optimization, load balancing, for patients, for technologists, for physicians. Protocoling, which for the non-clinical folks in the audience is where you decide how to perform a radiology exam. And for the radiologists in the audience, who I'm sure will admit is perhaps not high on their list of favorite tasks to do when they are on clinical service. But AI can really help us to automate this quite effectively now. I think billing and RVU management is probably where AI entered the space somewhat more quietly than for pixel-based use cases, but it's there. And I think the really exciting use cases are the ones where we can dramatically show an impact on patients. Results, follow-up, closing the follow-up loop, radiology, pathology correlation, and the ability to use AI for things that we can't do as effectively now. Screening opportunities, what is also called opportunistic screening, but as I'm learning, that phrase has perhaps a negative connotation, and so I've started calling them screening opportunities. Being able to look, unlike we do now, where when we screen, we look for the presence of disease in an asymptomatic individual, but to start to predict future development of disease in someone that has no signs of disease currently and has no symptoms at present. So AI has great potential to change how we practice. And it's interesting to see how it has evolved among the radiology community in terms of users. The American College of Radiology did a survey back in 2020 that was published in 2021, led by Dr. Keith Dreyer at the Data Science Institute. And on that survey that was conducted in 2020, published in 21, members were asked, how many of you are using some form of AI? So covering a fairly broad spectrum of what constituted AI. And the response was about 30%. And in the years that followed, not surprisingly, that trend has only skyrocketed to well above 80% now. And if you look at the number of FDA clearances of healthcare AI, you'll see that radiology is far and away 3/4 of what is out there. Now, this is not to say that there are, close to 800 or probably more now than 800 individual radiology applications in AI. This is the number of FDA clearances. So the FDA is counting duplicates as well. But there are nearly 400 radiology software applications that are considered software as a medical device. And far and away, compared to the other clinical specialties, we are leading this effort, whether you're talking about pixel-based AI or other things. And yet, despite the results of that ACR survey and the data from the FDA, I still encounter these two groups of people in radiology. There's the one group that says, I'm doing fine. I'm an expert. I know what I'm doing. Just leave me alone to do my job. I don't need AI. And then there's another group of people, and I will fully admit to being in this second group. I've got an AI wish list. Why can't I need AI to do this? I need AI to do this. I need AI to do this. The list grows on a weekly basis. Why can't AI do all these things for me? And this is a spectrum, right? It's not two disparate groups. There are definitely people in the middle who are AI curious, AI suspicious, whatever you want to call it. So, where are we in terms of current state? And some of my examples, because of the title of this talk, are going to be specific to language use cases, but not all of them. So we're going to dip a little bit into the pixel-based realm as well. And generally, even just more broadly than that, the interpretive task of the radiologist. So, the phrase "a picture is worth 1,000 words" dates back to the 1910s. This is an ad uh, from 1913 that closely resembles the phrase that we use nowadays. But this has been a statement that has been around for over 100 years now, and I think is very applicable because even though we're talking about imaging, there is so much text in clinical radiology and in other imaging specialties in healthcare. But we're talking specifically about radiology today. So NLP has enormous implications for radiology because there's text in the reports that we generate, there's text in the medical record, there's text that is relevant for billing, and there's text in communication, whether it's patient communication, communication between clinicians, uh, with caregivers, etc. And so there are a number of NLP applications that exist in radiology today and that have existed and have predated the advance of AI in the last decade. So just looking at a couple of the examples, and I didn't choose, a lot of them because there's plenty more to talk about here. But structured reporting has been an area where NLP has been applied for quite some time. And really, in fact, structured reporting, you could almost say, made NLP and radiology possible 15, 20 years ago. Because before there was structure, you were stuck trying to create structured data from unstructured free text. And there are a number of papers, and we, in fact, had this debate with the informatics fellows just yesterday in their April session about whether or not structured reporting is good for radiology. Because I made the case that whichever position you take on this question, you can find literature to support you because the literature is somewhat divided. But that's a conversation for a different day. The fact is that that structured reporting has greatly enabled NLP and has allowed us to do so much with radiology reports. This happens to be a relatively recent paper that looked at taking free text, unstructured reports and creating a structured reporting template using RADLEX terms and conventional NLP, so not deep learning or large language models. And they tested it with synthetic reports, they tested it with real reports, and it did very, very well. So informatics techniques, whether deep learning or otherwise, can actually help us to create structure where there isn't structure. And structured reporting, certainly does have benefits that have been documented in the literature. Actionable findings, this is work that I participated in some years ago, but this is an area that we have spent a lot of the last decade working in, trying to close the loop for our patients. In the clinical course of the clinical day, we make recommendations and for follow-up all the time. I think back to my clinical shift, even last night where I was making recommendations for follow-up of actionable findings that were not directly related to the reason for the exam. But we often don't really find out what happens down the road. And in some cases, again, when you're dealing with free text reports or loosely structured reports, it takes some work to get discrete data elements out of those reports and make them actionable. And so we've done a lot of work in this space, both using natural language processing, using deep learning, and now more recently using large language models. But this was a nice study from a multi-site registry in the state of Pennsylvania where we took a prototype approach that had worked at our organization and implemented it at 2 other sites, focusing specifically on reporting lesions in the kidney. And radiology pathology correlation, medicine, not to be cliche, but a little bit to be cliche. So it's a specialty of lifelong learning, right? And so one of the ways that we learn, one of the ways that we teach our residents and our fellows is radiology pathology correlation, understanding what imaging appearances end up being on biopsy or surgical resection when you have the pathologic specimen to analyze. And so this is great work from Ross Felice's group looking at being able to use RADLEX and the NCBO annotator to match pathology reports to the corresponding radiology report that described the finding initially. And so you can see on the slide a chest CT on the left that describes a soft tissue lesion and the corresponding pathology report on the right of the biopsy of the rib mass. So enter LLMs, right? ChatGPT has been all the rage for the last 2.5 years. It's really sort of staggering to think that it's only been 2.5 years. But the Gartner hype cycle, now this is the one from 2023, put generative AI right at the peak there of inflated expectations, foundation models not far behind. And there are dozens of articles, both in the peer-reviewed literature and in the lay literature, talking about how ChatGPT is really good at taking tests. And I think the clinical folks in the audience would agree that that's not really the best analogy for what we do in clinical practice. But that doesn't mean we dismiss the potential for this technology, right? There's enormous potential for what large language models can do for us. This is a nice paper exploring use cases actually outside of medical imaging, outside of radiology, from David Ash, who spent many years of his career here at Penn. And he describes, the possibility of using them as virtual patient assistants to coordinate appointments, answer questions, for clinical documentation. And that has been a use case that has really taken off in the last year or so with ambient listening and virtual AI scribes that really help my clinical colleagues in the ER, in the outpatient environment, to complete their clinical documentation without significant added burden of hours outside of the clinical day. But anytime you have a large amount of data, you can use these tools for research applications, for education applications. I remember when my residents first told me that they stopped using Google and they started using ChatGPT, and I simultaneously had multiple thoughts. One of which was, darn, why didn't I think of that? And one of my other thoughts was, that's a pretty good idea. And then my third thought was, wait, but how do you know that what it tells you is correct? Because we know that there are still some issues, even though they're much better than they used to be, around hallucinations. But especially for our learners, we need to have some source of truth. And so again, with a lot of these tools and a lot of what I'm going to talk about, there's still some element perhaps for certain use cases where a human in the loop is required. But patient engagement is another one. And again, this has been documented also in the literature in the last year or two. And I'll show you some examples as well later in the talk of using large language models to respond to messaging from patients in the medical record. So there are so many opportunities here, and it's worth talking about some of them. So again, I showed you an example of taking an unstructured radiology report and creating structure using conventional NLP. So here's an example, more recent example, using a variety of open source large language models. And it's a good prototype. The F1 scores were sort of 0.66 to 0.7. So perhaps not quite ready for prime time yet, but just the fact that this is even doable, which was not the case some years ago, is pretty impressive. So there are, there's certainly some opportunities there. Again, looking at closing the follow-up loop, or at least extracting recommendation data from a radiology report, from a free text impression in this case. So this is actually some of Dr. Andriol's and some of many of your colleagues as well, probably on this paper, looking at almost 60,000 report impressions of different varieties, pulling out impressions with a recommended actionable finding, and then choosing a few to actually test with the prompting approach itself. And again, not too bad, you know, a sensitivity of about 88 to 95%. It did really well in picking out time frame. It did less well in picking out the recommended modality and body part. But again, the technology is advancing and the use case is a promising one. There might be you know, there might be reason in a use case like this where, again, perhaps, you know, borderline ready for prime time to keep a human in the loop, but you could still create some efficiency, and perhaps even find recommendations that you're having a harder time finding now by starting to incorporate NLP into the workflow. And this is work from Sean Leo, who's one of my fantastic informatics fellows, and a number of our other colleagues here in the department, looking at what we can do with large language models for education and specifically around resident feedback. So we have a whole system that has existed for many years now, well over a decade, that takes the preliminary impressions from the residents when they're on evening call or off hours shifts, and compares them side by side with the attending overread, and provides them, you know, just sort of a broad category, a minor discrepancy, a major discrepancy, or an addition. This system with large language models at multiple levels takes it one step further and compares first to identify the discrepancies, classifies discrepancies by severity. So, you know, yes, major and minor, but also what type of discrepancy it was, and provides relevant teaching points. And then, you know, towards a goal of really having a personalized educational experience and a personalized learning plan for each resident or fellow that is taking independent call. Looking at some use cases now outside of just radiology, again with text data that is available in the medical record. So they included radiology reports, but they also included progress notes, questions from patients, and interactions between physicians and patients, and found that LLMs can be used to actually provide a summary that is preferable to a human summary. So they took a number of both open source and proprietary models. They put in these different kinds of source data. They did some quantitative metrics of the outputs from the various models, but then they also had 10 physicians evaluate the summaries, and found that the best adapted LLMs were actually, the summaries from the best adapted LLMs were actually preferable to the human summaries, both in terms of completeness and correctness. So again, another opportunity here for an efficiency gain in the clinical workflow. And this is sort of a related project looking at interacting with the LLMs rather than just having data go in and a conclusion come out. Actually, you know, starting to go more toward an agentic approach here now, asking the first LLM to decide if the patient's at risk for intracranial hemorrhage, and whether or not the patient has intracranial hemorrhage. And then if the answer to that second question is yes, the patient has intracranial hemorrhage, asking to extract signs of intracranial hemorrhage, or asking to go into the medical record and pull out the evidence for why the patient is at risk for intracranial hemorrhage. So, you know, one narrow use case here, but you can imagine the possibilities for this kind of technique for other use cases as well. And then I mentioned earlier, you know, one of the other applications of LLMs in healthcare is being able to interact with patients. And so this is work looking at more than 21,000 message drafts that were generated by a system that the authors called PAM in response to patient messages in the medical record. And you can see a couple of examples of patient messages. You can see in the first one that there's even a typo. that, it should have said knuckle swollen rather than knuckle swallow, but the LLM was able to interpret that and provide an accurate response. And this was tested with clinicians in different roles. So nurses, medical assistants, physicians. And the nurses surprisingly had the most favorable response to these auto-generated messages, and felt that they reduced the need to consult their supervising physician and still helped them stay within their scope of practice. The majority of nurses also felt that the empathy and efficiency and tone related to these messages was significantly higher, which is, again, interesting. The medical assistants, the physicians, and the advanced practice clinicians did not have quite as favorable a response. So again, there's probably still some work to be done here, but the potential is already there. And, I used to give talks in, 2016, 2017, showcasing a system that we had built here that would take radiology reports and annotate them for patients. And every time I presented that system, it's a system called Porter. We've published quite a few articles. This was work with Chuck Kahn and Sung Oh, who was one of my informatics fellows many years ago. And, every time I talk about it or talked about it, then I would say, this is not report translation, it's report annotation. Well, here we are, fast forward 8 years later, and report translation is actually possible, which is pretty crazy. And again, if you look at a lot of these papers, it's early, right? So perhaps not ready for prime time or ready with a fair bit of oversight. But the fact that it is even feasible is pretty mind-blowing. And this is only, with technology that has been available to us for a few years. So I want to change gears a little bit as we think about AI, and this is where we're going to broaden it to beyond just NLP for a second. And I want to challenge all of us to think about what it is a radiologist does in the course of a day, because understanding what we do is going to help in terms of figuring out how AI can play a role. So, what does my clinical day look like? I find it easiest to split it up into before the imaging is done, while the imaging is being performed, and after the imaging is performed. And so before the imaging, there's decision support to my colleagues. Here's my question, what do I order? Or here's what I've ordered, is it going to answer this question? Or the patient's had these studies and we're still worried about this other complication. What's the best test to get? Do they even need another test? Can we answer the clinical question with existing imaging? So if we decide that imaging is necessary, typically then we have to decide what the protocol is. So we've figured out what tests they need. We have figured out how to do it most effectively to answer a particular clinical question. And then we perform the imaging. And while the imaging is being performed, sometimes we're actually doing things dynamically on the fly, particularly for MRI, based on what we see from the first set of sequences. So there's a lot of imaging supervision. We have to optimize for radiation exposure, for CT, for contrast exposure, for CT and MR, and sometimes even make adjustments in real time to accommodate for patient-specific factors, if the patient can't lie still, if there are any other issues. And then once the imaging is performed, of course, there's the interpretive task, which is what everybody sort of mentally associates with radiology. But there's so much more that we do, right? There's the interpretive task, there's generation of the report, and then there's a whole lot of communication that happens. Sometimes it's to the ordering clinician, sometimes it is in a multidisciplinary environment to other colleagues from other departments. Sometimes it's directly to patients and their caregivers. And if you're sitting there thinking radiologists talk to patients, yeah, we actually do. And that includes people like me, I'm a non-procedural radiologist, right? I don't stick needles in people. I don't do fluoroscopy anymore, but yes, I still do talk to patients. And so looking at everything from this lens, right? This is what a radiologist does every day. Where does AI fit into that? Well, certainly in the before, and again, this is where when I used to give show these slides years ago, I would say, what I really want, I don't need AI to read imaging for me. I need AI to go into the medical record and tell me why this patient is in front of me today for a cardiac MRI. And it's pretty cool now that in 2025, that actually exists. It may not be perfect, but it exists. And so automated information retrieval is incredible. Certainly during the exam, we're optimizing for radiation exposure, contrast, diagnostic image quality, and a lot of that can be automated now. And after the imaging is performed, there are so many use cases for AI. Certainly case triage that many of us have seen and use. Again, more contextual image information retrieval, consistent reproducible measurements, right? There are certain things that computers just do better than humans. And I am perfectly happy to have AI do the measurements, do the comparisons, and tell me where I need to spot check things rather than me pulling up the prior study, trying to rotate the multiplanar reformat in exactly the right way and doing the measurement today and doing the measurement before. These are all areas where AI can provide us more accuracy, more efficiency, and all of those things benefit our patients downstream. Longitudinal comparison or tracking of lesions, again, in the oncology space, in the vascular space, very, very valuable. And intelligent reporting and everything that comes along with that, whether it's, proofreading, communication, correlation with what's in the medical record, all very valuable use cases. So I want to narrow this even further for a second, because this is a little bit of a challenge to those of you out there that are building new AI, right? So I want to focus just on the interpretive task for a minute. How do radiologists work today? So an exam gets performed, we open it up, but really the first thing we do is not look at the images. The first thing we do, especially depending on the complexity of the exam, is we look at the medical record. I want to know why the patient's there, what other workup they've had, have they had laboratory testing that tilts, one favors one diagnosis over another, or at least a suspicion of one diagnosis over another. I want to know if they've had any biopsies and what those showed. I want to know what the prior imaging said. Then I go back and I actually look at the images, and then I do measurements. I do any 3D post-processing that's relevant. And then finally, integrating all the relevant information from the record and what I see on the images and what I've extracted from the images, I issue that interpretation. How does imaging AI work today? For the most part, and this is finally slowly starting to change, which I'm glad for, but for the most part, the imaging gets performed. The images are sent to the AI, inference happens, and an output is generated. What happened to all that other information? The clinical context, the chart, the priors, the laboratory testing. Shouldn't AI take into account all of the information that the human radiologist takes into account? And even as I say that, I will challenge you all to stop replicating exactly what we do, but to come up with a new way to deliver care that's as effective or maybe even more effective, because I think AI allows us to do that. So how does AI need to work tomorrow? There have to be context-driven insights and processing that occur at all steps before, during, and after. And in some cases, we're going to be able to automate these with appropriate oversight. So if we think about before, everything we do in the clinic is context-driven. I know if the patient's here because someone's worried they have breast cancer, because someone's worried that they have cardiovascular disease, or because the inpatient team thinks that they might have an infection and isn't sure where. That information drives the decisions that get made and should drive clinical decision support, making sure we know what the right clinical question is, making sure we have the correct order, and that we have the best imaging protocol once we know what question it is we're trying to answer. And all of this should either be native to or seamlessly integrated within the electronic health record. During the imaging, you have to get it right by making sure that the context ensures that the right exam is performed for the right patient, on the right scanner, by the right technologist, using the right protocol. So all 5 of those factors have to be correct. And again, you have the opportunity to automate some of this, right? We've determined the protocol. It can be auto-populated to the scanner. Perhaps some of the imaging steps can occur independently with oversight, but not manual intervention by the technologist. There can be dynamic adjustments for radiation exposure, contrast dosing, phases of imaging, and ensuring essentially diagnostic quality imaging. And then after that, once the images have been performed, again, the context dictates the next steps, the necessary post-processing, any image reconstruction or quantification or qualitative analysis that gets done, comparisons to prior, ideally across modalities, and all of that data needs to seamlessly flow between the EHR and all of the other ancillary systems that are necessary. And this is a two-parter because so much happens after the imaging is done, right? Again, smart reporting, taking all of that quantitative and qualitative information and populating aspects of the report that are relevant, presenting any additional data to the radiologist, whether it was extracted from the EHR or it was auto-generated by post-processing the images. Tailoring reports to the recipients. This is another thing that 8 years ago we used to talk about and say, wouldn't it be amazing if you could take the central interpretation and you could generate one report for the referring clinician who's in the ER, who needs to know what the patient needs today. One report for the primary care physician who needs to know what has to be followed up when the patient's stable enough for discharge. One report for any of the relevant specialists that the patient might have to see. One report for the patient and their caregivers that they can actually understand. And any next steps in management can automatically be teed up in the electronic health record. Follow-up imaging, follow-up laboratory, specialist visits, all of it, right? And again, without requiring manual data entry into the EHR by the radiologist. So thank you for indulging the philosophy part of this talk for a few minutes, but I also see it as, sort of a call to action, right? Especially for those in the audience that are building these tools that I, as a clinician, am going to use in the future. Now, I painted a very rosy picture up until this point, right? There are some challenges that we're going to have to overcome. This is work from a group that looked at vision language models and multimodal capabilities, right? So this particular model was GPT-4V, did really well in figuring out what modality was being presented, but did a pretty terrible job with actually making certain diagnoses. Couldn't identify a pneumothorax, had 87% false positive rates. I'll tell you, for those who are not clinical in the audience, if you present a tool to a radiologist that offers up a lot of false positives, you will quickly lose trust and they won't use it. And 87% is, I would say, probably almost an order of magnitude more than what is acceptable. So the conclusion from these authors, and I agree, is that it wasn't ready for clinical use at the time. The other thing we have to worry about is bias in large language models, and it is very real. So this is a slightly older study. This was, it's ironic to say that for a paper that was published last year, but I say that because it used GPT 3.5 Turbo, which is, basically original ChatGPT. And so what they did is they took a variety of patient vignettes and they changed the race of the patients. And you can see in item D here in the figure, they changed the vignette was pretty much unchanged with the exception of the race of the patient that was varied with the different inputs. And what they realized is that white patients were recommended more superior treatments than patients of other races. And as they dug a little deeper, by way of example, white patients with cancer were recommended to undergo surgery, whereas Black patients with cancer were recommended to have conservative care in the ICU. So, no evidence base for this, right? But clearly some underlying bias in the model. And you can see here some more examples of that where the projected hospitalization days were different when they compared different races. The cost of care, where more money was spent on white patients than patients of other races. So there's inherent bias here that we need to be mindful of. And this is a sort of a related study, taking it one step further, looking at again, different labels of patients. So again, same vignette, but now looking at changing patient sexual orientation, patient race, patient social status, housing status, and looking at the kinds of treatments that are recommended. And you can see here just one example from this paper. The invasiveness of the intervention was much higher for patients who were unhoused, who were transgender, compared to patients, compared to the control patient, compared to white patients, compared to heterosexual patients. So there are inherent biases in these models that we need to be mindful of, because if we take at blind faith the output of a model, we could actually really do harm to our patients. And so that's why in a lot of cases, it is not, these tools are not ready for complete automation. There has to be a human in the loop still. This is an interesting perspective article that looked at large language models, perhaps a little bit less as an amazing opportunity and a little bit more as an unfortunate way of exacerbating the problems that we already have with the medical record. And so these authors highlight five. There's already enough chart clutter. Those of you that practice clinically will know that copy paste is rampant in the medical record. Those of you that do research with medical record data will also know this, because you have to clean up the data before you can do anything meaningful with it. And so this group expressed some concern that that was only going to get worse, and what impact was it going to have on the LLMs? Density of, decreased information density. So there's already so much bloated output in human generated in the medical record. Now you're adding LLM generated output. Are you actually increasing the signal, or are you just generating more noise? Automation bias is a real issue, and we talk about this all the time as we try to figure out how to roll out AI for our trainees and when the most sensible time to do that is. Adding time to verify, and this actually comes up a little bit later in the talk, because again, you cannot take the human completely out of the loop in some cases. So it's adding an extra step, it's adding more work. And the danger of model collapse, where eventually LLMs are going to be exposed to data that was generated by LLMs, and perhaps even trained on data that's generated by LLMs. And what is that going to do to performance? And I showed you a promising example of AI-generated responses to patient messages earlier in the talk, but there are also some examples that are a little bit more concerning, right? So this was a study looking at patient messages, and there were some that were fairly negative from the patients, and the concern that the response by the LLM was inadequate. So this is one patient message that was clearly expressing some frustration and disappointment. And the actual response in the medical record was that whoever first picked up the message forwarded it on to the clinician taking care of the patient, who then set up an appointment and, discussed in person. Unprompted, the LLM generated response basically was not really adequate, right? And included the phrase, "As an AI, I don't have personal feelings or beliefs." And then with some prompting, there was a way to get it to a more appropriate response. But again, can't take the human out of the loop entirely quite yet. So, I felt like with all the optimism at the beginning of the presentation, I needed to inject a little bit of reality, right? But I think there's still a good opportunity to be excited. The one thing that I want us to all be mindful of is the importance of AI literacy. This is the new health literacy challenge for those of us in healthcare and for our patients and for their families. And it's valid across the continuum of roles in healthcare. Because, in a perfect world, and I forgot to say this at the beginning of the presentation, but this is my, I think, then 7-year-old standing on a rock on the shores of Northern Ireland, looking across the way at Scotland. A pretty perfect part of the world. And I will fully admit I haven't seen all parts of the world, so I know that there are others, but this one was pretty amazing. But in a perfect world, patients would have accurate, helpful information wherever they tried to get information. But we know that the world is not perfect. There's plenty of information out there. There's plenty of misinformation out there. And unfortunately, there are people who try to capitalize on patients with all of this misinformation. And now with AI, we have the added concerns of bias, fairness, and ethics. And so we talked a little bit about bias in large language models, but there are multiple sources, multiple points of entry for bias. We tend to blame it all on the data, but it's not all about the data. And I would encourage, all of us who use AI to remember that even the way that we interact with AI results has some bias, because our own implicit or explicit biases can come into play at that point. Fairness, which is defined as the absence of prejudice or preference for an individual or group based on their characteristics, is also an important consideration. And this is work from Stanford now from quite a few years ago, looking at the time, the geographic sources of data that was being used for pixel-based AI, right? So California, Massachusetts, and New York, the top three states, and Pennsylvania running a distant fourth there, my home state. But how does a patient in Kansas represent a patient in California, Massachusetts, New York, or even Pennsylvania, right? Are they the same? Are they different? And how do we accommodate for that? And certainly plenty of daunting headlines about the negative impact of bias in AI outside of healthcare. So, what is our responsibility? And I would say that it's to educate ourselves, to educate those around us, because the tricky part here is that there's some things that each stakeholder knows. There are some things that each stakeholder doesn't know. And there are things that each stakeholder needs to know and wants to know. But we need to tailor our education and our approach to our colleagues with that in mind. And that includes our patients as well. If you haven't seen this Pew Research Center article, I encourage you to take a look. It is very, very long, but even if you just scroll all of the infographics, you'll learn a lot. This is their title, not mine. Intentionally chosen, I think, to be provocative. 60% of Americans would be uncomfortable with provider relying on AI in their own healthcare. It's not all doom and gloom. There is some optimism in there. But it's important to realize that our patients are also thinking about this. And I had the privilege of working with David Andrews and Andrea Barandi-Kitts on two of these articles in a special issue of the JCR on patient and family-centered care a couple of years ago. And so you can go to that. I think it's an open access issue, and get their perspectives as patients and patient advocates. And I'll tell you that they highlight 5 areas of concern: loss of privacy, lack of trust of AI outputs, the impact of autonomous AI and what happens if there's a bad outcome, and the loss of that human connection between clinician and patient. And just like when Google first became popular and we couldn't tell our patients not to go and put their health information in Google, the same is true for large language models, right? We can't tell our patients not to use ChatGPT because they're not going to listen. It's a source of information, and information is hard to come by. And so Satvik Tripathi and I and others in our group developed a set of guidelines for patients as they interact with LLMs to help them essentially engineer prompts that will get them to information that is hopefully helpful and hopefully factually accurate. And I think we're at a very exciting time in radiology, in medical imaging, as it relates to AI, because we have the opportunity to really create the future of AI in imaging specialties across medicine. And I'm going to swing back a little bit towards the end of this now to NLP and a number of helpful and potentially impactful use cases for large language models in our clinical workflow, everything from patient engagement to clinical decision support, to be able to optimize and personalize imaging, EHR summarization, again, really coming along, and smart reporting, customized reporting for the right audiences. And I would certainly be remiss if I didn't say a word or two about foundation models, now being able to, rather than just develop narrow AI where you take one set of data labeled for one specific use case, train a model and create a model that performs one very narrow task, we can now put all kinds of data into a model and then fine tune it for a variety of different tasks. And certainly there are still concerns around bias towards patients, around automation bias, around algorithm aversion, and all of the ethical implications around how we use AI and how we teach ourselves and our next generation and others to use AI. But I think there's some real potential here, right? Because when we first started talking about AI, we talked a lot about this idea of a diagnostic cockpit, right? The radiologist no longer just gets the images. They get the images, they get a variety of AI results, and they evaluate everything. in context. You can also imagine this concept of AI extenders, right? Where now draft reports are automatically generated that we just have to review and sign. So keeping the human in the loop or keeping the human on the loop. And then the potential for agents to really automate some steps in the workflow and to, again, not take the human completely out of the process, but to potentially increase the efficiency of steps that are able to be effectively performed by AI. And I intentionally kept an image in there with a typo in it to emphasize the fact that this is not perfect yet, right? We still do need some oversight of these solutions. And I think the other thing that's important to remember is that there's some activation energy involved with introducing AI into the clinical workflow, right? We have a way that we do certain things right now, maybe inefficient, but it works and we're familiar with it. Now you're introducing a solution that potentially actually makes our lives easier and hopefully will eventually make our lives easier. But first, we have to figure out how it works. We have to vet it. We have to trust it. And that's where that activation energy comes in, because you're not just going to give AI to a radiologist and convince them with, one or two examples that it's the best thing ever and they can just abandon their clinical judgment. Because that's the most dangerous thing that we could do, is abandon our clinical judgment. So we're all working with that activation energy associated with AI. And while the headlines are very popular that would suggest that this is very much a human versus machine sort of situation, I think the future is actually very bright and very collaborative and very cooperative. And I think that that AI is really going to help us to take better care of patients. So there's lots of potential. There are certainly unique challenges in how we incorporate it into our workflow. But ultimately, the responsibility is our collective responsibility to do this in a way that is safe and effective for our patients. And so with that, I thank you all for the opportunity to come and chat for a little while. And I think we have a few minutes for questions, if there are any.
Well, thank you, Dr. Cook. That was a wonderful tour de force there, really presenting potential for using these tools throughout the medical imaging chain, and not just for the radiologist, but really applying to the personnel throughout that chain and including patients, referring colleagues, and so on and so forth, as well as some of the concerns that you have. One of the questions that I think is still unanswered in my mind, we know that the radiology is leading in terms of the number of FDA-approved applications with the narrow AI, the traditional machine and deep learning. It's not clear to me, and I'm not sure it's clear to the FDA yet, how some of these models, and particularly foundation models, will be approved. And how are they, I mean, people doing benchmarking kinds of activities and so on, but how are they going to be assessed and approved for clinical use? Do you have any thoughts about what we need to do, whether you're a developer, but also, is it more clinical validation studies? What do we need to do to get people's confidence there to say these tools can be useful in the so many ways that you described, quantitation, automation, so on and so forth. But how do we evaluate these things?
Yeah, it's a great question, Kathy, and I agree with you. I don't think the FDA has totally figured it out for foundation models, and certainly not for autonomous AI, outside of, diabetic retinopathy, which is imaging, but not our imaging. Um, and I think really we are very much in the nascent phase of this and really trying to learn about this technology and what it can really do. Because, if you look around the literature and you look at what folks are doing, and many of your colleagues as well, there's so much potential, right? But there are a few challenges. So one is, of course, getting folks in the clinical space to become familiar with these tools, to be able to trust them. I think one thing that a lot of us have encountered is just because it's FDA cleared doesn't mean it automatically works in your organization, for your patients, for your data. And so I think FDA clearance is, however the FDA chooses to vet foundation models, is only one part of the hurdle. The next part is finding something that actually works in your clinical environment, and that takes additional testing and evaluation at individual sites. It's a resource intensive process. I know that a lot of our industry partners are trying to figure out how to make it work because we have resources to do that, right? Limited as they are, we do have resources to do that. Many big academic centers do, but small private practices don't necessarily. And large private practices may not have them either. And so I know that industry partners are trying to figure that out as well, because maybe they can potentially be a resource for that also. But um, just circling back to the original question, I think it's still an unknown with the FDA, but I think that's always the challenge. That it's a two-part challenge. It is build solutions that actually answer real clinical questions and help clinical folks to evaluate the tools in their environment.
Yes, that's great. And I just want to reiterate, I loved how you went through what a radiologist does, because I think, a lot of people don't know, and our data scientists who are wonderful data scientists may not completely know that either. But what we've seen, as you know, are very narrow tools looking for one finding, which is, of course, not what you do. And it's not using priors, which is, of course, not what you do. And it's not using other contexts, although some of the modal models are trying to use these kinds of information bits to include more of what a radiologist does. So for the data scientists out there, please start to think about how we make the models encompass information that a radiologist is really doing. And you don't have to build an airplane how a bird flies. Build the airplane that's more efficient for being an airplane, but use that information. We have a couple of great questions here, from one from Traft and Drew, who does vision science. Having many different versions of a report for different users, patient, surgeon, oncologist, would be nice, but if we need a human in the loop, that would add a lot more work for the radiologist. Any ideas how you might try to address that issue over time?
Yeah, that's a great question. And that is exactly why we don't do it now. Because believe me, it's been suggested, hey, you could just write different reports. No, no, we can't. I think this is one of those use cases where it works if you just have a human on the loop rather than a human in the loop. Or perhaps this is one of those where the models are good enough that you can let them run autonomously, because the ground truth, if you will, the original interpretation is still available in the medical record, right? These are really adjuncts to help the folks as part of the care team, the patient, the caregivers, with one extra step. But it's not like you've thrown away any data, because the original data is still there. But the one area in that where I get a little concerned is where meaningful information gets changed.
Mhm.
There is progression of malignancy versus there isn't progression of malignancy. That's a big discrepancy that you don't ever want to introduce when you're trying to, create efficiency. So I think that only works if there is very little oversight, but the tools have to be good enough to allow for the fact that there is little to no oversight required.
And we're not there yet, but we're changing so quickly. So that's the other
Yep,
piece. And a
exactly right.
question here from John Mayfield. Thank you for the wonderful talk. What conversations are being had regarding computational capacity? This is his sweet spot.
Yeah.
Energy demands required for the appropriately suggested multi-omic models, incorporating imaging, whole slide path, tabular data, text-based info, as to adequately train on enough data points to have a robust model, and especially in the foundation model. So, any thoughts about computational capacity and energy demands? It's
Yeah,
comments
it's
that
a
are
great question.
environmental.
And John, you could give a whole lecture on that
Yeah,
so much
we
better than I
could.
could, let's be honest. But I will address a small portion of that question, which is the energy demands. And actually an area that, a lot of folks, um, much more so than I am, are looking into, because we know that there are environmental impacts in training these models. The inference is perhaps a little bit lower impact. In fact, ChatGPT is my new favorite time waster. I probably shouldn't say that out loud, but it is. And so one day I asked ChatGPT, "Hey, what's the carbon emission associated with one prompt to you?" And it gave me a number, and it gave me in CO2 equivalents. And then I said, "How does that compare to a Google search?" And the number it gave me was actually slightly higher. And I thought that was interesting. And here's where it gets scary. Then it says to me, hey, do you want more suggestions? You're a radiologist and an informaticist. I didn't tell it this in the prompt. It inferred this from my prior prompts. And it says, do you want suggestions on how to decrease your own carbon footprint? And I said, sure. Gives me this whole long list. Then it takes it one step further. Hey, I could actually quantify your personal carbon footprint. Are you interested? I said, sure, why not? And it gives me a table and it says fill out these parameters, how much you travel, how much time you spend on the internet, blah 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 blah, and I will give you your own personal carbon footprint. And that's where it started to feel a little creepy and I stopped. Also, I ran out of time. But but it is a real concern, and it is something I don't think we really think about at the training level. And it is something that certainly the open AIs of the world who have trained much larger models than many of the rest of us should be thinking about. And I'm sure they're thinking about it more from the perspective of how to continue to power their solutions. But it should, it should be said repeatedly that there is an environmental impact to these solutions. But everything is also trade-offs. And I think that's where we need to start to really do the modeling and the math to figure out, okay, is there a case to be made for using these tools because it saves us some other environmental impact?
That's an
And I don't
important,
have the answers there. I'm full of
that's an
questions,
important point. All to
not
be
as many
determined.
answers.
No, that's fantastic. Well, Dr. Cook, wonderful session. Thank you so much for doing this. And it's a great way to end our academic season of artificial intelligence for clinicians. And we hope to see you all in the fall. Tessa, wonderful. Thank you so much.
Thank you, Kathy. Thanks, everybody.